Good morning, everyone. This is a pre-briefing session, and our title is Acute Kidney Injury. We have three doctors: Dr. A, Dr. B, and Dr. C. Dr. A, that is me, would be the principal investigator. Dr. B would be the assistant, and Dr. C would be a simulated patient. The setting is a primary care clinic, and it's in the emergency department. And Dr. C will be simulating patient is coming with a complaint of decreased urine output and bilateral lower limb swelling. So we'll be proceeding with first history, a brief history, followed by examination, then followed by investigations and symptomatic management. Thank you. Namaste, Mr. C. What is the problem that brings you here today?
Namaste, doctor. Recently, I have noticed that my urine output has been decreased significantly, and also I have noticed some swellings in my both lower extremities. So I was worried about it, and I admitted.
Did you recently have any signs of infection like fever, diarrhea, or vomiting?
About a weeks ago, I had severe diarrhea, and I had been for that I took some over-the-counter medications also.
And do you have any chronic problems like diabetes or hypertension?
Yeah, I have been taking medication for hypertension, I guess 5-6 years. For 5-6 years, I've been on anti-hypertensive medications, doctor.
Are you taking any other alternative medicines like herbal medicines, or are you taking any? Do you regularly drink alcohol or smoke?
For the diarrhea, I took antibiotics for 2 weeks, and also for my lower back pain, I have been taking ibuprofen.
And did you take antibiotics under the prescription of doctor or by yourself? And can you tell me which antibiotic did you take, if you know the name?
No, doctor, I didn't consult for that. I just went to the clinic and took some medications.
Do your family have any similar history, like you mentioned before?
I guess no.
Did your parents have hypertension?
Yeah, my father is hypertensive, and he has been taking anti-hypertensive medication for 3 years.
And in the urination, did you notice any unusual pattern, like any frothy urine or any reddish discoloration in the urine?
Yeah, initially the color of my urine was yellowish, and now it has been a little darker than that. I don't know if it is a blood
Okay,
or
was it red stain? What is?
yeah, sometimes.
Was it frothy?
Yes.
Okay, so is there anything more you can say? Is there anything?
No. Do you have any problems regarding the dribbling of urine or any hesitancy or frequency of urination?
No, I do not have such problems, doctor.
Do you have any previous history of prostatomegaly or prostate-related problems?
No, I have not been diagnosed with such disease, doctor.
So, are you having any pain around your back of your abdomen that radiates towards your groin region?
No, doctor.
No such problems.
No, I don't.
Okay.
So, Dr. B, I think we are done with the history. So, I think we should proceed with the examination.
I think we should move with the physical examination.
Yeah, first we'll perform some general examination. So, Mr. C, what we are going to do is we are performing a general examination. In that, we'll assess you from head to toe, and we'll notice the finding. And after that, we'll do the system examination. So, right now we are suspecting that you have some kind of genitourinary problem from your symptom. So, we'll do the system examination regarding the genitourinary. But first, we'll proceed with the general examination. So, can you sit up so that we can do general physical examination?
Sure, doctor.
Okay, can you turn towards that side, towards the light?
Okay.
So first we'll be performing your eye examination to check for pallor and icterus. Can you look above? Okay,
Good.
There seems to be some mild degree of pallor, isn't it, Dr. B?
Yeah, there's some mild degrees of pallor.
Can you look down? There is absence of icterus.
Yeah. So can you please show us your tongue?
Can you take it out?
and the
Yeah.
dorsal part of the tongue.
So even in the dorsal part of the tongue, there seems to be some degree of pallor, but in the
Yes.
ventral there is absence of icterus.
So can you show us your palms? So there are
In comparison to
Okay.
my hand, so there is some
mild degree of pallor,
pallor,
is present
but
with the
absence
hand.
of icterus.
Okay.
And let's just proceed with the lymph node examination. So I will be going to the backside of the patient, checking for submental lymph node, checking for submandibular lymph node. Can you turn your head slightly on towards this side? Checking for anterior group of neck. Can you turn this side? Checking for anterior group on the right side. Let's proceed towards the back side. Checking for the left posterior cervical lymph node, right posterior cervical lymph node. There are no pre-auricular lymphadenopathy, no post-auricular, and no occipital lymphadenopathy. So there seems to be no lymphadenopathy on lymph node examination.
So probably this is not any infectious origin.
Yeah, this is not infectious origin. So Dr. B, can you check for cyanosis and clubbing?
Okay. So can you please bring your hands forward? So I'm looking for the presence of clubbing. So first I'll be taking about the distal interphalangeal joints. There seems to be no signs of clubbing. And also, can you please put your fingers like this way? So the Samerth window is well maintained, so there is no any degrees of clubbing is there. So can you please show your circummoral areas? Okay, so there are no any signs of cyanosis are there. So this rules out the respiratory and the cardiovascular, the central causes of the cyanosis. So probably there is no any problem in those systems.
So Dr. B, is there a sign of dehydration?
Okay, so to check out for the signs of dehydration, so I first need to see his oral cavity. Can you please see oral cavity? The oral cavities, there are some degrees of dehydrations in the oral cavity, so we'll be
Dr. B, can you proceed with the skin toric examination?
okay. So can you please bring your hands forward? So to is it okay if I touch your hands?
Yes.
So to proceed with the skin turgor test, I will see the turgidity of the skins. There is the late retraction of the skin after pinching. So again, it suggests some degrees of dehydration in this patient.
So there seems to be dehydration. Now we'll proceed with the edema, if there is any presence of edema or not. So can you please move forward your legs? So I'll be pressing the three areas. First on the dorsum of foot for about 20 seconds, 15 to 20 seconds that is, and see if there is any kind of peating edema present or not. So for 15 seconds I'll be pressing. I think it's about 15 seconds, and I can see there is some form of peating edema in the dorsum of foot. So I'll again move 5 centimeter above the middle malleolus and see in the shin area. So there is peating edema here also. Similarly, Dr. B, can you proceed with the right leg?
Okay, the presence of peating edema in this patient suggests some kind of volume overload.
Yeah, so
Alright, so there's bilateral pedal peating edema, suggestive of some kind of volume overload. So either the renal system is involved or the cardiovascular system is involved. So the patient is not having cyanosis or any other feature suggestive of the cardiovascular origin. So the cardiovascular system is ruled out. So most likely the patient is having the involvement of the renal system.
okay. So now I'll proceed with the renal system examination. So Dr. B, I'll be doing the renal system examination. So Mr. C, can you please again lie down in the same position as previous before? Is it okay if we move your t-shirt above a little bit so that we can expose? Okay, we are exposing. So Mr. C, we are exposing from the epigastrium towards the pubic symphysis. Ideally, it should be in the mid thigh, but for your convenience, we are doing till just above the pubic symphysis. So I'll be first inspecting the movement of your abdomen with respect to respiration. So I'll be doing from three sides. From your right side, it seems to be equally moving with respiration, and from the leg side also it's equally moving with respiration. Similarly, from the left side also it's equally moving with respiration. So all quadrants of the abdomen are moving equally with respiration, and there are no any visual pulsation or
No any visual lumps are
lumps,
there,
yeah,
and no any scars are there.
no visual peristalsis. So inspect your findings is not
It looks normal.
normal.
On inspection.
So let's move with the palpation. On palpation, I will be first checking for local rise in temperature. So I'll be comparing with the thorax. So I'm doing in the all quadrant, upper, lower, left and right side. So there is no any superficial rise in temperature. And I will see for tenderness in the patient. Are you feeling pain? There are no signs of grimaces and patient denies feeling of pain. So I'll see for pain in the deep palpation. Since the patient does not show any grimaces and denies the pain, so there is no tenderness on deep palpation.
Okay, so let's move with the organomegaly.
So Dr. B, can you do the organomegaly test?
Okay, so I'll be assessing the two organs, the spleen and the liver. At first, I'll be palpating your liver.
Okay, Dr. B, so I think we should relax his abdominal muscles. So,
Okay. So
can you put your
in the semi-flex
Chest
position?
position,
You can put your legs. Alright. So can you please take a deep inspiration? Alright. Now another item inspiration. Relax. Another item inspiration. Relax. Another item inspiration. Relax. Another item inspiration. Relax. So there is the liver is not palpable. Now I'll be assessing the palpation of the spleen. So again, can you please take a deep inspiration? Now expire, deep inspiration, expire, deep inspiration, expire, deep inspiration, expire, deep inspiration, expire. So the spleen and the liver are not palpable. So let's move with the palpation of the bimanual palpation of the kidneys. So
okay,
Dr.
so
A, can you please proceed with
yeah,
the bimanual
I'll-
palpation?
So with my non-dominant hand, I'll be putting towards the back of the patient, and see from my dominant hand I'll see if these kidneys are bilaterally palpable or not. So kidney is currently not palpable, so there is no any yeah, there's some, I can feel some movement, palatable movement, so that's likely kidney, but it's not enlarged.
Yes.
Okay, so following that I'll be going towards the percussion of the abdomen. Start from the epigastrium region and move towards the symphysis pubis, and then again go upward and laterally. So that is how I will proceed. As we can hear, there is tympanicity present in all the quadrant. So there is no any dullness. So that proves that there are no any fluid accumulation or any mass. So the abdomen was tympanic. Now Dr. B. So following percussion, now I will move with the loin tenderness and renal angle tenderness. So Mr. C, can you please sit up?
And the position.
So Mr. Dr. B, so you proceed with the renal angle
Okay.
tenderness.
So proceeding with the renal tenderness, I'll be. So is it okay if I lift your t-shirt?
T-shirt.
Sure, doctor.
Okay. So here is the boundary is made by the electrospinal muscles and the inferior rib of the 12th rib. So I'll be percussing along your ribs. So if you feel any pain, so you can complain. So So are you having any pain here?
No, no, doctor.
Positive line. So similar on the other side. So are you having any pain?
Patient is showing sign of grimaces, so there is pain.
Yes,
I think.
doctor, it's painful
So-
here.
There is renal tenderness on his left side. So probably
So Dr. B, so what does this suggest?
So it suggests some kind of renal pathology in his left side. So it could be any regions, any pathology that is affecting his left kidney.
So since it's renal tenderness, most likely it's upper urinary tract, isn't it?
Yes, suggestive of upper urinary tract involvement.
So now proceed with the auscultation. Is there any renal pre or hepatic pre? So last that will be our last physical examination. Then right now we are having some idea. Then we will proceed with the investigation.
So Dr. A, can you please proceed with the hepatic and the renal pre?
Okay, thank you, Dr. B. So can you lie in the supine position? Can I take off t-shirt? About 2 centimeter laterally in the paraumbilical area, I will listen for renal bruit. So there are no any renal bruit on both the side. So that rules out any kind of stenosis in the renal artery. Similarly, in the hip, in the lower coastal region, right coastal region, I will listen for hepatic bruit, and there is absence of hepatic bruit, so there is no any signs of portal hypertension. And on the paraumbilical region, on the left side and right side, I will listen for bowel sound for about a minute. I'll count the number of bowel sound for about a minute. So in a minute, he is having about 6 bowel sound, which appears to be normal.
Yeah, that's normal.
So our examination complete. So let's move your t-shirt down. So Dr. B, on some, let me summarize what he said. So on the basis of history, he had some volume depletion, and he is also taking over-the-counter NSAID, some kind of antibiotics, which he has no idea of, and he also has a history of hypertension. So all suggest a risk factor for renal pathologies. So, and again in the physical examination part, we had renal tenderness. Again, that shows renal pathology of upper urinary tract. So this is most likely a case of genitourinary system, and again since there is a history of volume depletion, so that again points towards some kind of renal kidney injuries, and again that is not chronic in nature. So most likely it's some form of acute insult. So how will we proceed, Dr. B? I think first we will be doing the renal function test, see if it is deranged urea creatinine and it deranged sodium or potassium. Then most probably we go with the routine urine examination and microscopic examination to see for any crystals or protein or any epithelial cells or WBC cast. Then next, what will Dr. B?
So in addition to that, again proceed with the ultrasound of the renal system. So in the ultrasound, we can look whether there is any the differentiation between the cortex and the medulla is well preserved or not, whether there is any shrunken kidneys which suggest of the chronic pathology is there, and if the corticomedullary differentiation is well maintained, then it's less likely of the chronic injury.
Okay. Based on our history, so what will be the provisional diagnosis, Dr. B?
So for the provisional diagnosis of Dr. C, so is having the acute form of kidney injury, and for acute form of kidney injury there can be the prerenal, renal and the post-renal cause. So, these features are suggestive of the prerenal and the renal etiology. For the prerenal, the points favoring as he was having the features of dehydration, and that might have led to hypovolemia, leading to the prerenal form of the acute kidney injury. And also he was taking over-the-counter medications that might have led to acute tubular necrosis, that leading to the renal form of the acute kidney injury. So do you think there can be any other differentials for this patient?
Okay, I think there are no many other differentials. So this is like the acute kidney injury, maybe. So most likely this out of the differences that you gave, most likely could be acute kidney injury, but we do not know whether it's pre-renal, renal, or post-renal. So for that, we need to see the investigation report.
So concluding for him, so he is having pathology involving the renal system, probably the pre-renal or the renal form of etiology, and for the further diagnosis, we have to proceed with the further urine reports and the ultrasound of his kidneys.
For now, Dr. B, I think we should ask him to discontinue the nephrotoxic drug that he is taking, NSAID, and we'll do some fluid management.
We'll maintain the hydration of him, and also we'll maintain the electrolyte balance have to be maintained.
So I think for now we'll do that, and we'll see for the reports and proceed further. Okay, Mr. C. So that would be it.
So thank you for your time.
Thank you, doctor.
Thank you very much. Take 11. Take 11. Good morning, everyone. This is a debriefing session titled Acute Kidney Injury. So we'll be discussing the problem that is likely to be faced by the patient party and the examiner. So I am Dr. A, the simulated primary examiner. Dr. B here will be the assistant examiner, and Dr. C is the simulated patient. So I'll be starting with the problem that patient might face. I think so there was a problem of privacy. We should have maintained curtains, and also from the examiner's side, if there was more lighting, so it would have been proper for the pallor and icterus examination. And for the assistant part, do you have anything to say, Dr. B?
No, it was okay for me.
Okay, so and our proceeding was from the history to the examination to the investigations, and prior to investigation we made some provisional diagnosis and did investigation according to that, and we symptomatically managed the patient based on the history finding. Thank you.